All right, thank you very much, Frank. All right, for this patient, I think I would like to highlight the transcatheter ASD closure in a patient with pulmonary atresia with intact ventricular septum. All right, thank you. All right. Pulmonary atresia with intact ventricular septum is characterized by either a membranous atresia of the pulmonary valve or sometimes RVOT muscular atresia, and there is intact interventricular septums. The important features that we need to undertake is the various degree of the hyperplasia of the tricuspid valve and also the right ventricle. So the treatment option for this group of patients varies from biventricular repair. The patient may need only radiofrequency valvotomy and balloon valvotomy, or even to the Fontan procedure as a single ventricle physiology. And some of these patients undergo only the Glenn shunt as a 1.5 ventricular repair, or this is especially for patients with a borderline right ventricle, and usually in this group of patients, the interatrial defect like ASD or even the PFO are often left opened, and as a safety mechanism to decrease the central venous pressure and to maintain the cardiac output. However, there are very limited reports about the interatrial defect device closure for PAIVS patients. So the objective, actually we have 20 or 19 patients underwent the interventional device closure for the interatrial communication. So I will be highlighting only one area of challenges in managing a patient with a PAIVS. All right, so this is a 13-year-old boy who was diagnosed pulmonary atresia with intact ventricular septum early in life at day 1 of life. So this is a prostaglandin ductal-dependent cardiac morphology. So we have started this patient on prostaglandin and underwent a successful radiofrequency valvotomy followed by PTBV and the PDA stenting at day 10 of life. All right, so if you see the angiogram pictures here, this is a very nice illustrate the PAIVS with inlet component of the right ventricles and also the outlet component. The apical trabecular components is very rough, and then you see there's a lot of trabeculations. So what we did for this group of patients is a perforation of the pulmonary valve followed by the small coronary balloon at 3 millimeter diameter, and later on final dilatation using the Tychet balloon 8 millimeter. So for the bipartite RV, all right, this is our protocol to put in the PDA stent, because we know that the bipartite RV, they were unable to provide enough lung circulations. So at the same times, we were going to usually put a PDA stenting. All right, so this is a routine follow-up for all patients with PAIVS. The 2D echocardiogram, we look for the RV volumes, tricuspid valve and mitral valve diameter, the degree of the tricuspid regurgitations, pulmonary regurgitations, and also the RVOT gradients. And clinically, we are going to take the oxygen saturation, symptoms, and also the growth of the child. So this is an example of one of the follow-up for these patients. So there's a better improvement of the right ventricle. It's a very mild tricuspid regurgitations, and there is quite a good forward flow into the pulmonary circulation, and in I think certain the view you can see the very minimal PDA flow. All right, so I tried to summarize the follow-up assessment for the past 13 years, and then you see the tricuspid valve regurgitations maintained from mild and doesn't progress more than that. All right, and tricuspid valve diameter is quite good progress. I think you see the improvement of a size of the child, and also you see the Z score of the tricuspid valve from minus 2.1 to the latest follow-up to minus 1.4. And the mitral valve diameter is maintained at the minus 0.5. And you see the tricuspid valve and mitral valve to mitral valve ratio from 0.7 to 0.88 at the latest follow-up. And PDA flow, even we stopped the aspirin, the PDA stent flow was still present. And ROT gradient doesn't seem to be increased and maintained at in teens. And also no increments of the pulmonary regurgitations. And what we notice here, the oxygen saturations maintained at the low 90s, all right, from the post-procedure until the latest follow-up in the clinic. So this is the follow-up assessment, the latest follow-up assessment. You see the interatrial defect here, all right, it's a bidirectional shunt, and the tricuspid valve regurgitation remains at mild stage, and one of the pictures showed a very good RV volumes, and the PDA flow was still present through the stents. All right, so what do you think what we should do next? Observe or continue the follow-up? Or close the ASD? Or case study, we reassess the right ventricle. All right, so that's, or some of you might have a cardiac MRI, so cardiac MRI might be able to assess the RV cavity properly. So what we decided was to proceed with a transesophageal echo and a cath study with intention to close the ASD. So you can see, I think one of the speaker, I think in yesterday's session, has highlighted about the malaligned septum. So this is not uncommon to have a malaligned septum in patient with pulmonary atresia with intact ventricular septum. So you see this PDA, the ASD, which is a bidirectional shunting, and then this is the superior septums, and we see there's a malaligned septums is clearly seen on this view as well. All right, and there is a mild tricuspid regurgitation. All right, so then we decided to close the PDA and the ASD. So this is the routine cardiac study, that cardiac angiogram that we do. All right, sorry. This one, is it? Oh, sorry. Previous one, sorry, the previous one. Okay, thank you. Okay, so this is the routine 4 chambers RV assessment that we do. All right, the catheter through the retrograde into the LV, and also integrate from into the RV. We assess right ventricle and left ventricle simultaneously. You see this RV is well apex forming. All right, and there's no branch PE stenosis, and hemodynamics also showed good oxygen saturation, but this patient is ventilated, but the LA saturation is 90%, so there is a bidirectional shunting. RF pressure mean of 11, and the PA pressure is normal, and there's no significant pullback gradient from the PA to the RV, and the QPKS was 1.4 and PVR was 2.2. So the PDA was closed retrogradely using the ADO2. All right, there's no residual PDA shunts. But however, there is the ASD. Then we need to decide what kind of closure that we need to do. Do we need to do balloon sizing? All right, and then hemodynamic study for the RV compliance. So we decided to put in the balloon. So the balloons, there's 2 objectives. One is to assess the size of the ASD, the actual ASD. At the same time, we need to test occlusion of the ASDs, and then at the same time we put the catheter into the SVC to measure the systemic pressure, systemic venous pressure. All right, so this is the dopamine stress before we occlude the ASD, because that ASD might be the only safety mechanism that the patient has before we close the ASD. So we need to decide either this is we can do it safely or not. All right, so you can see the heart rate with the increment of the dosage of the dobutamine. So the heart rate increased, and then you notice the blood pressure comes slowly coming down. And but what interesting, you see the CVPs, all right, from the mean of 10 to mean of 18. All right, so you may say this is because of the balloon, because balloon probably too bulky. All right, so we change that to the device itself. All right, and the pressures is still the same. All right, however, the tricuspid regurgitations remain mild, and you see that oxygen saturation, because there's no more right to left shunting, so the oxygen saturation increased. And at 20 mic, you see the patient has SVT. That you know that this is the RA pressure is high, causing the arrhythmias. So then what should we do next? All right, do we need to deflate the balloon and abandon the procedure, or proceed with ASD device closure with special precautions, or fenestrated ASDs device closure? So we decided to fenestrate the device. Okay, at the moment we don't have a registered fenestrated ASD device. So what we did, we cut off the fabrics inside the device. So this is, I think, the Occlutech device. All right, and then second question is, of course, you can do a very good cut off at the fabric inside the device. The nitinol wire, they have the memory. Okay, they will conform into the same shape after the implantations. All right, so that's one thing. And secondly, do you think this device is safe? All right, because there is a high RA pressure, so it's comparison to the PFO device, which is a bigger RA disc, and the normal, the ordinary ASD device. So, but we decided to put in the ASD device. All right, so this is the result. Okay, so the fenestrations work quite well. CVP maintains, and you see the fenestration through the echo here. And patient was discharged 2 days after that. And there is no facial edema. The patient so far well throughout the follow-up. Oxygen saturations maintained at 99%. And you can see the fenestrations during the follow-up as well. So the take-home message is the transcatheter interatrial defect occlusion for PAIVS patients is effective procedure with high success rate. But the main indication of closing ASD in PAIVS is right to left shunts. It's either because of the cyanosis or low saturations, or because of the paradoxical embolizations phenomenon. And secondly, if there is a large ASD causing the left to right shunts. And of course, in this group of patients, you need judicious considerations, especially to decide on the appropriate device size due to high risk of device embolization because of the malaligned septum. So with that, I rest my case. Thank you.